Welcome to another episode of Technically Sleeping. This topic is hypothermia. I'm Kimberly Hassan, and I'm a boarded veterinary anesthesiologist. There are a lot of reasons to care about hypothermia. The first one is that hypothermia slows metabolism, which leads to a prolonged anesthetic recovery. Another problem with hypothermia is that it causes stress to the heart. This is because, for one thing, hypothermia causes vasoconstriction, which increases resistance that the heart has to pump against. Another problem is that hypothermia leads to shivering, which dramatically increases oxygen consumption by up to 300 to 400%. Very severe hypothermia can lead to fatal arrhythmias, like ventricular fibrillation. Another problem with hypothermia is that it delays wound healing and has been demonstrated to increase the risk for surgical site infection. There are a few ways that this happens. So for one thing, hypothermia is immunosuppressive, and that it decreases the activity of your immune cells. And then the vasoconstriction that's inherent to hypothermia decreases blood supply to the wounds. Hypothermia decreases activity of all your body's enzymes. This also includes your coagulation factors, so you can get increased blood loss from hypothermia. For every degree Celsius drop in temperature, blood loss may increase by up to 20%. Hypothermia also decreases MAC, or increases anesthetic potency. So for every degree Celsius drop in temperature, MAC drops 15%. So if you're not careful, this can lead to an anesthetic overdose. And finally, people who wake up cold from anesthesia report that it's extremely unpleasant, and this is probably true for our animal patients as well. The first thing to understand about why our patients get so cold is that the hypothalamus in the brain is responsible for maintaining body temperature. The drugs that we give our patients depress the hypothalamus, which means that any response to hypothermia is impaired under anesthesia. So if you look in the image in the center of the screen, this depicts how responses to body temperature change, including hyperthermia, which leads to sweating in those species that do sweat, or vasoconstriction and shivering in the case of hypothermia, occur at certain body temperatures. But under the influence of anesthesia, now all of this changes. So the patient has to be even colder before vasoconstriction or shivering occurs, and these are responses that help to blunt hypothermia. But these in turn are impaired under the influence of anesthetic drugs. Another problem is that a lot of the drugs we give our patients under anesthesia cause vasodilation. When you're vasodilated, all the heat that's in your body can escape more easily. So propofol, alfaxolone, acepromazine, isoflurane, sevoflurane, these are drugs that cause vasodilation and facilitate heat loss. And then when you have an anesthetized patient, it's not awake, it can't go crawl under some blankets or head for somewhere warmer when it's under anesthesia. And these are all reasons that anesthetized patients are so likely to get hypothermic. All of our patients are at risk for hypothermia, but there are some who are more likely to get colder than others. Smaller patients definitely are in this category. So a small patient has a high surface area to volume ratio, or body surface area to mass ratio, which means that there's a lot of body area from which they can lose heat relative to how much core heat they have inside. Any patient that doesn't have a lot of hair to insulate them, also at risk for getting colder. Doesn't have a lot of body fat, it's at risk for getting colder. Radiology, CT, those are just hypothermic vortexes. Those patients are at risk for becoming hypothermic if they go to radiology, any kind of imaging before surgery. If you remove the insulating fur coating on your patient, that also increases the risk for hypothermia. An important concept to understand in understanding hypothermia is the core versus the periphery. Your core, your trunk and head, your internal organs, your brain is always warmer than the periphery, including your peripheral extremities, your skin, your subcutaneous tissues. So normally you have a gradient between the two. The outside of your body is just a little bit cooler than the inside of your body. That core versus periphery concept is important to understand when you're trying to understand how heat loss occurs. This graph here depicts what happens under anesthesia. On the x-axis, you have elapsed time, and the y-axis, the change in temperature. So you notice within the first hour of anesthesia is when the most dramatic heat loss occurs. This is due to a phenomenon called redistribution hypothermia. In redistribution hypothermia, the core part of the body starts to lose its heat to the periphery, and so now there's no more gradient between core and periphery. This is the most dramatic heat loss that occurs under anesthesia. The next phase is when the animal decreases heat production because of a decrease in metabolism. The third phase is a plateau phase. So now the decrease in metabolism that's decreasing heat production is matching the heat that's being lost for the animal, and the drop in temperature levels out. There are four main ways that heat loss occurs, and it's important to understand them and understand their contribution to hypothermia so you can know how to prevent hypothermia from occurring in the first place. Radiation, or the heat energy transfer between objects that aren't touching, is actually the most important way that our patients lose heat under anesthesia. Convection, where air currents carry our patient's heat away, is also very important. Evaporation, or the transformation of liquid to a vapor, important too, especially when you have an open body cavity. So all of your organs have a layer of liquid on them, kind of like an isotonic saline type variety. And anytime that this liquid is evaporating, this takes your patient's body heat in order for that transformation to occur. And this is why evaporation can be a problem. This is why you notice that a patient having a laparotomy is going to get colder than one having a simple small mass removal. The respiratory tract also has heat loss from evaporation, but this contribution is actually quite minimal. Conduction, or the transfer of heat between objects that are actually touching, has a variable contribution to hypothermia depending on what exactly your patient is touching. The best way to treat hypothermia is to prevent it in the first place. One reason is if you remember the graph of the rate at which heat loss occurs under anesthesia, if you prevent that first hour of rapid heat loss, you've actually gone pretty far to addressing hypothermia. The other problem is once you have the redistribution hypothermia and your patient starts becoming vasoconstricted, it's really hard to get heat back into your vasoconstricted patient, to get that heat into the blood to warm the patient's core again. So there's some really good ways to prevent heat loss. The best way, and this has been demonstrated scientifically in human studies and recently in a veterinary study too, is to increase the operating room temperature. This prevents the radiation heat loss, which, if you remember, is the biggest contributor to hypothermia in our patients. This is problematic because you can imagine asking a surgeon who's in a gown under a hot light, who's trying to concentrate, to turn up the heat in the room. They're not going to want to do that. Another thing that you can do is use an insulating space blanket, and that can also help to prevent radiation losses. It's really important to take conduction out of the equation if you're considering putting your patient on a cold steel surgical table, any kind of radiology table. The floor that's cold, don't do this. This helps to make your patient really cold. So cover any cold surfaces with at minimum a blanket or a towel, but really what's best is a circulating warm water blanket or an electrical resistance blanket like a hot dog. If you don't have a forced air warmer at your clinic, you should get one. These are very effective at preventing hypothermia, or at least ameliorating it. So you might have seen, or you might do this yourself, where you take a bear hugger and you just blow it at the patient without the blanket. Don't do this. There's a couple reasons why you should not do this. One, you're not getting as much warm contact with the patient. Two, you're at risk of burning the patient if they're too sedate to move away, and that heat is perpetually warming the same focal area. Three, corneal ulcers. If you have a big enough blanket to put your patient on top of the warmer so that the warmth kind of encircles the patient, this has actually been demonstrated to be a bit more effective than putting the blanket on top of the patient. You can also imagine too, if you have a very large surgical area, it's really difficult to get coverage with the forced air blanket unless the patient is on top of the blanket. Other ways to help prevent heat loss include not using alcohol in your surgical prep if you can. So anytime you have something evaporate, that takes heat from your patient. Evaporating alcohol takes even more heat than taking saline. So this is why with very small patients, I will use Chlorhex and warm saline rather than Chlorhex and alcohol for their pre-surgical prep. Blankets are good. They prevent radiation and convective losses. But remember, unlike a forced air warmer, there's no additional heat provided. They're more just preventing heat loss. And then it's interesting to think about where you're going to put your patient coverings. So limbs actually lose heat quite quickly. There's a relatively large amount of blood flow, so that heat is easily lost from the limbs. If you wrap the limbs in socks or plastic wrap, that can be pretty effective. There was actually a study in veterinary surgery in 1997, and they looked at putting coverings on the limbs versus the trunk, and those animals that were covered in their limbs were less hypothermic than those that were covered in the trunk area. There are some other products out there that aren't bad, but aren't necessarily the greatest. So heat and moisture exchangers, they prevent evaporative losses from the respiratory tract. But remember, those only really account for about 5% of heat losses. So there might be some downsides like increased dead space or increased resistance to breathing or contamination. Some people really like them. I think that they're not going to be the make it or break it in preventing hypothermia. Your fresh gas flow rate is cold, dry gas that's going into your patient, so it too contributes to hypothermia. You can consider turning down your fresh gas flow rate in a cold patient. Coaxial breathing circuits, where you have a tube within a tube, like this F circuit here, can theoretically facilitate warming of inspired gas, and that's because the patient is inspiring through the inner tube, expiring through the exterior tube. The expirations are designed to warm the inspirations in this circuit. Fluid warmers, controversial. Remember, your fluids can only be so warm, so it's not like you can put boiling water into your patient to warm it up. You would need really large volumes administered really fast to increase your patient's temperature. The other problem is that if you're going to take a fluid warmer for a really small patient, imagine that that patient is on a very low fluid rate, and the fluid warmer can only get so close to the patient. So as your fluid is traveling through the line at, say, 10 mils an hour, it's probably losing heat to the environment before it ever gets to your patient. However, you can imagine that giving room temperature fluids is not doing your patient any favors. So delivering slightly warm fluids to your patient is better. Do not use electrical blankets or anything warmed in the microwave. They can cause burns. And remember, an anesthetized or sedated patient cannot just get up and walk away when it's starting to feel too warm or starting to get burned. The best way to treat hypothermia is to prevent it in the first place. However, if you're looking for something, you can use warm water lavage. So if you have a laparotomy, you can consider asking the surgeon to use a warm saline lavage. Bladder and rectal lavages are also available. You can use those even if the body cavity isn't open. But again, preventing that initial rapid drop in body temperature is the key. Pre-warming is really great in theory, the theory being that if you warm the periphery to be the same temperature as the core, you can prevent redistribution hypothermia from occurring in the first place, which remember is that rapid initial drop in body temperature. Unfortunately, a couple veterinary studies exist where they attempted to do pre-warming in patients, and they were unable to conclude that pre-warming was effective in preventing or even reducing hypothermia. In conclusion, anesthetized patients are highly susceptible for hypothermia, and we talked about why that is. Hypothermia increases the risk for negative outcomes. Hypothermia is bad. Please don't use heating pads on animals. And remember that the best way to prevent hypothermia and the best way to treat hypothermia is to prevent it from occurring in the first place.